So for Chapter 9, we're going to be looking at the toddler and preschooler developmental phases. Some of the information is going to overlap the two. Some of it I will specify how it differs among toddlers versus preschoolers. So we start off with our objectives, like we've had with the previous chapters, where we're going to be identifying the normal patterns that we can expect in terms of growth and development, as well as assessment. And then we're going to focus on what are those safety risks and how do we help to minimize them. What is appropriate as far as education and other nursing interventions for the patient, especially in terms of topics like pain and approach to assessment, and then just some specific challenges that are unique to each of these developmental age groups. So the first thing to understand is that the toddler developmental phase is going to consist of kids who have had a first birthday, so age 1, through age 3 years. And you'll notice that age 1 actually overlaps our infant and our toddler population, just like age 3 is going to overlap our toddler and preschool. And so one thing to consider is, it's going to be an individualized basis as far as what you can expect from that child, if they're going to more resemble the infant patterns at age 1 or the toddler patterns at age 1. Important principles to be mindful of. We talk about Erickson and his stages for each developmental phase. Autonomy versus shame and doubt really captures what these kids are experiencing in the toddler phase. We know toddlers have the association with being terrible 2s and terrible 3s because usually they do have some tendency for tantrums and other defiant behaviors, and a lot of times it really reverts back to their trying to gain self-control, trying to establish that autonomy. And the more that they succeed in that, the better their self-confidence will be. When they experience shame and doubt, that's going to then inhibit that self-confidence or that self-esteem. Egocentrism, I think we had that previously, where we have the inability to see things from another person's perspective. It's why, again, there's so much defiance or disobedience oftentimes with this age group, but that's very normal for them. And then anal stage is going to pertain to Freud and how in this stage we would expect them to be concerned with their anal parts, which is also appropriate considering they are going to be toilet training in this phase as well. And we do see some understanding of the ability to follow rules. They do so more out of fear of the consequences, and even that sometimes is not the case for the toddler. Motor development, they're going to be able to do things like walk alone, run and jump, climb furniture, kick a ball, turn a doorknob, and so we also really see safety being a concern at this age because of their increased ability with movement. Their language skills, they should be able to say words. It may not be a very expansive vocabulary yet, but they should be able to recognize objects. They might be pointing instead of saying what they're pointing at. They are probably going to begin repeating things that they hear, and for some kids, especially the closer they get to that 2 and 3-year-old phase, they're going to be able to say things in phrases and even short sentences. An important concept to be mindful of is that they can understand far more than they can say, which is where it says receptive far exceeds expressive. And that again leads to a lot of frustration because they understand you and they want to communicate in response to that, but they don't always have the words for that communication. Additionally, this is where we see a pattern called telegraphic speech, which is where they just say the most important words. So whereas a 4 or 5-year-old might speak a full sentence like, I want pizza for supper, a toddler is probably going to just give you the, main points like eat pizza, because that's what they are trying to send the message of. And we call that telegraphic speech a lot like a telegram, where you used to have to pay for the words that you sent in that message, and so it was only going to be those crucial words that were included. Cognitively, we do see children begin that understanding of object permanence, where when something's hidden, it's actually still there and they can look for it. And so things like playing peekaboo or even playing make-believe will start to become a thing in this age group, but generally further out in the toddler phase. They can identify colors and shapes as well, and this is really when we want to provide them choices, because anytime they have the opportunity to make that decision, that's going to increase that sense of control. Now we want to make sure that the choices we're giving are ones that are appropriate. So it can't be things like, do you want a shot today? Because they don't have that choice if that's what's needed for this visit. But we can ask things like, do you want the shot in your left arm or your right arm? Do you want a sticker or a sucker afterwards? So things that they can actually have some influence on. And remember that routines, schedules, that's all very helpful. The more you can maintain that, generally the better the behavior of that toddler. Socially, the milestones that we see here is that they do engage in play called parallel play, which means that they'll typically play alongside another child, but they may not actually be playing together or, interacting as far as turn taking. It's more going to be like, I see you playing with the doll, so I'm also going to play with the doll. We'll see the imitation of other people or other behaviors here. So, if they see mom or dad generally on their phone, they may grab some object that looks, rectangular and put it to their ear and start babbling as though they're also talking on the phone. They can be very affectionate at this age, and that's something that we typically expect to see, but they can also be very defiant, express jealousy, especially in a situation like, receiving a new sibling. And again, a lot of that comes from the inability to regulate those emotions or express those emotions appropriately. Separation anxiety is also very high during this age. It peaks at 10 months and persists through 18 months. So we'll see a lot of that when they're apart from their primary caregiver. When we look at the preschooler, we're going to see a different Erikson stage, and so for them, it's going to be initiative versus guilt. Initiative being that, desire to take action, be assertive, and again, assert some power and control over their environment. As long as they're able to do that, that's going to boost that morale and that self-confidence. If they aren't able to, then they're going to develop those feelings of guilt and reliance on other people. This age group, we see that magical thinking surface where sometimes it just doesn't seem plausible, the mental associations they're making. For example, a sibling may become sick and they may think that that's because of something that they did that was bad to that sibling, and they caused that sibling to become sick. And then we also look at them now progressing from anal to the phallic stage, phallic meaning genitals or genitalia, and this is where they tend to start really observing that in themselves and in others. They're exploring, and that's a very normal part of that, but it does still require some education from the caregivers and potentially some, limitations or restrictions on where that exploration is permitted. And then with moral reasoning, we've kind of talked about they don't want to get in trouble, so there's that fear of consequence that might have led to them, obeying. Now we're starting to see more of that obedience because they do have some concept of right versus wrong, and they do recognize the consequences that they may receive if they aren't acting correctly. Anytime we do need to correct behavior in a child, it is very important that we're labeling that behavior, not the person, as being bad. For example, that was a bad choice, that was a bad, behavior when you hit this person or when you lied about this versus you're being a bad child, you're a bad boy or a bad girl, because that can again begin to create that shame and doubt and that guilt complex that will hinder their achievement of these important milestones developmentally. For them, as far as motor development, gross and fine, they should be able to start, dressing and undressing independently. They're brushing their teeth. They're going to the bathroom by themselves because hopefully in this time frame they're potty trained or close to it. Ambulating up and down stairs. They have more dexterity with their hands, so they can use utensils, a cup without a lid, scissors, throw and catch, all of these different things. And so again, the more active they become and the more coordinated they become, we have different safety concerns that we need to be mindful of for them. In terms of language, we should be able to understand a preschooler when they get to be this age, even though sometimes they may use, a different pronunciation of a word than is typical. That's okay, but we should still be able to recognize what they're trying to say. And that would be a concern if, you weren't able to understand the child at this age, that there may be some speech or language delay. They begin to tell stories. Sometimes they're not true. That's very normal. That imagination and creativity, that playing pretend really comes into play here. They should be able to tell you their name and maybe even start to, recite some things like where they live or maybe even the parent's phone number. And then they also do have this literal interpretation of language. So sometimes when we use euphemisms or expressions, they may take that literally. For example, if you were to look at the weather yesterday, you may have said, "Oh my gosh, it's raining cats and dogs." Well, that preschooler might really be looking for cats and dogs falling from the sky. So you do have to be mindful of how that may come across. They are very curious at this age. They ask why a lot, and that questioning is actually really important because that's helping to develop, their intellect and exploration of knowledge. Socially, we should see them continuing that desire for independence. We should also see that ability to follow the rules. They may start exploring and finding new interests. A very typical thing for this age group is collecting things. I always give the example of my son. Both of them now have had this, we'll call it a hobby, where they like to collect rocks, and I'll usually discover it in the washer machine or the dryer when they're spinning, running around and making all kind of noise, but they just find something really intriguing about rocks. And so different kids are going to have different interest in that. In terms of play, they're progressing now from that parallel play where they're really just doing a similar thing but not necessarily engaging, to now what we call associative play. With associative play, we're talking about a child who is interacting with the other person. So they're actually playing together, maybe on the playground or maybe building a tower or, playing dress up, but it doesn't necessarily include that cooperation of like turn taking and equality or fairness. So, they may be tempted to say, well, you can have it for a minute, but then I want to have it for 5 minutes. Or you can take a turn, but then I want to take 3 turns. And so we're still working towards that cooperation level. They do, as said previously, show interest in exploration of genitalia and recognizing those differences in other gender. And they do have an interest in helping, so they do want to be given responsibilities to, say maybe do a chore around the house or maybe some kind of hobby that lets them participate. Our nursing assessment, when it comes to this age group, both toddlers and preschoolers, it's going to look very similar to the adult patient as far as health history. We're just not going to have as much information as we do with an adult. Our physical assessment, that's going to be something that we want to approach the least invasive assessments first and save the more invasive or intrusive things for later. Also, when it comes to pain, we want to do, least pain performed first, save painful or even like private assessments for last, so that they're not developing that, anxiousness or that fear the whole time. One important difference to note is head circumference versus blood pressure. Those are two different measurements that in pediatrics are not always performed on the same child. So what we typically do is if a child's 2 years or younger, they're likely going to have their head circumference measured. That's because we expect their fontanelles to maybe still be open. Remember, that posterior fontanelle closes very early, but that anterior, the one on top of the head, usually closes by 2. And then usually when a child reaches 3, they're no longer going to have a head circumference measurement. They're going to start having a blood pressure measurement. And that partially has to do with, the cooperation needed for a blood pressure measurement, the size of the cuff that's going to be appropriate for them. It's not to say that you can't take a blood pressure on a child younger than 3, or you can't take a head circumference on a child older than 2. This is just part of the routine physical assessment that we're speaking to. And this is a great illustration of how to select that appropriate blood pressure cuff size for the child. With children, we do know that, yes, they have the same bodies as far as, organs and, structures throughout the body. They have the same purposes, but they aren't just little adults, in that there are some very significant differences both anatomically and physiologically. And so there's actually a list of some of those for you in your text on page 176. I'll let you look for those. Something else to be mindful of that you probably don't see in the adult is the use of growth charts. Growth charts are meant to chart trends for a patient, both in how tall they are and what they weigh. In the earlier ages, it's used to mark their head circumference trend, and then as they get older, their BMI, and that is all to determine if a child is progressing with consistency along that growth chart. And that helps us to recognize a child who suddenly, has a big climb in their growth chart plotting, or even maybe falls off of the growth chart, that there may be some kind of concerns we need to further evaluate. Safety is very important in all children. We know that in the U.S., the leading cause of death in kids is unintentional injury, and that could be from a number of things, some form of accident, assault, other things as well. And so specifically, what we want to look at with this population is drowning, falls, and poisonings, because those are those leading causes. And the falls and poisonings is not necessarily going to result in death, but it is a very common injury for this age group to experience. So our nursing interventions in relation to safety will obviously be, to minimize and prevent as much as we can. So things like, keeping a gate across any, stairwell that they could fall from, checking the temperature of water and food and things they come in contact with, in the hospital, checking equipment, make sure that they're not going to get tangled up in cords or they're not going to trip over something. Anytime you have suspicion of signs of symptoms that may need referral to Child Protective Services. As nurses, we're mandated reporters of that, so being mindful of that. And then something that's important, especially in that preschool age group, the 3 to 5, is that we recognize the need to teach them things like an evacuation plan, so that in an emergency they know where to go, because a lot of times kids will hide with fear of something, and that can be very dangerous, especially in the case of like a fire, because we may not be able to locate them to get them out. So instead we need to teach them, you want to exit the house or the building and go here in the event of. Another safety measure would be a safe word, something that they can learn to say the caregiver if there's some kind of danger and they maybe can't specify I'm in danger. They use this word for that. And I'm not going to read through all of these. Pay attention to the hot water tank should be 120 degrees Fahrenheit or less. That's an important rule of thumb. But all of this is very common sense, but it's still a good idea to review how, excuse me, how we can ensure safety for these kids in relation to their caregivers. And this list is just a continuation of that. Notice it mentions cutting food into bite-sized pieces and avoiding things that would be choking hazards, and that's a lot of things, more than you might realize. Nuts are included in that, popcorn, hot dog weenies, so need to be cut up in quarters, hard candy, especially that does not have a hole in the center like a Lifesaver. Because if that gets obstructed, it will occlude their airway. Grapes is another example. Grapes should be cut into quarters. Coins like money, latex balloons, and that's just some of the edible things. Well, latex balloons and coins should not be being eaten, obviously. But toys, you have to be mindful of too, like beads and things that are broken, or that could break off, would all be concerns for that. Another important thing to look at from this slide is that medication is never to be told to a child as the equivalent of being candy. We do not want to create that association, because then the belief would be, well, I can have as much as I want. But, we don't want them to become, to have that mindset for it. Okay, outdoor safety. For this, I just want to point out, it mentions using flotation devices, never leaving kids unattended near water, childproof in the area. A child is not considered a swimmer any younger than 6 years old, and even though they've had swimming lessons, they should still be supervised in the water. We never want to make that mistake of letting a child be out of sight from a guardian while they're in or near water. Also important that they know to be in an appropriate booster seat or car seat depending on their size, and those do differ depending on the state the child's in. Okay, for pain, a couple of things to consider. We do have some different scales for how we can identify pain. FLAC is one that does not require child participation. It's one where the healthcare provider is observing the child in different capacities, like facial grimaces, spontaneous movement of their extremities, these things. And so it's numerical and it's added up to give a score, if you will, and that's kind of going to help dictate what the measures are for that patient in terms of pain reduction. Faces scale is going to be on the next slide, and it's the pictures of the smiley faces and then the, kind of flat affect, and then eventually the sad crying face. That one does require child participation. And what's important to note is that they have to understand what they're doing when they select one for you to actually take their response as, a valid assessment of their pain. So if you can tell that a child's just picking a face based on what color it is, or, just at random, then it's not really giving you a true evaluation. You need to revert back to the FLAC scale in that situation. Very important to recognize the two most common pain reducers, which are also going to function as fever reducers, and that's acetaminophen and ibuprofen. We know of those in terms of brand names as Tylenol and Motrin or Advil, respectively. And you need to know what the appropriate dosage is. There should be a numerical range you learn of mgs of medication per kg of weight, and then also what is the concentration it normally comes in, and what is the interval frequency that you can administer those medications in. In addition, it's important to know what's the daily max dose for those, because, you know, giving a medication every 4 to 6 hours, well, if you give it every 4 hours, you've just given it 6 times in a 24-hour period. If you give it every 6 hours, you've given it 4 times in a 24-hour period, and sometimes that's necessary to know if you're going to reach or exceed that daily max dose for those meds. And then for distraction techniques, you know, that's just anything you can do to try to take the child's mind off of their pain. So, you know, guided imagery, deep breathing, music, play therapy, just some examples to consider. And these are some examples of the pain scales we were just talking about, FLAC and FACES. Okay, these last few slides are going to focus on some age-appropriate challenges, if you will, for this age group, and they each have some additional information with them, but I'll kind of go through that fairly quickly, and then you can always resort to your book for more information about it. So with potty training, we would expect that to be happening towards the end of that toddler range, and definitely, you know, if it hasn't already, it would be something they'd hopefully master in that early preschool range. Important thing is to know it's not a punishment thing, that we want to reward them, we want to encourage them, but not all kids are ready for this at the same time. And so it's important to give that information to the caregiver who's trying to potty train so they don't become too frustrated with this. We mentioned separation anxiety already, and how that's very normal and does create that, you know, distress in the child when they're apart from their primary caregiver. The main thing to do is, you know, give reassurance that that person will be back. We mentioned tantrums being very common in this age group, and a lot of times it's because of their inability to express themselves, and this is how they do that. Things to also consider are what are some of the triggers for that child. A lot of times, you know, they're either hungry or they're tired or they're sick, or they're stressed. And so that, if we can, you know, control some of that and minimize some of that, we might see a reduction in their tendency. And a great discipline approach for this would be timeouts. Timeouts are usually done a minute per age. So 3-year-old would sit in timeout for 3 minutes, and that is something that should be used consistently, because that is what's going to help to establish that expectation that if you don't do this right or you do this wrong, that's going to be the consequence. We definitely want to minimize use of spanking because of the risk for injury, and in some instances, especially the younger kids, like in that toddler range, they don't really have the ability to understand that the, you know, spanking or, you know, physical harm they're receiving is associated with the behavior they did that was not acceptable. For nutrition, we need to be mindful that it's very common for them to be picky eaters in both of these phases, toddlers and preschoolers, but especially toddlers. And one thing you'll hear referred to is called food jags or food fads, where they kind of fixate on a few certain food groups and that's all they ever want. And to some degree that's, you know, expected, and it's not going to ruin the child nutritionally, but what we want to encourage caregivers to do is make sure they're always offering new foods, and that they basically present what foods the child's going to eat, but the child can then determine how much of that to eat, which actually kind of coincides with this happy plate not being recommended. You know, a lot of times we'll say that, like, let's make a happy plate, but they've actually done research over the years that links that to more obesity in children, because we're forcing kids to finish what's on their plate and they may not actually still be hungry for that. Keep in mind that food allergies are a thing, but basically those can be, you know, they can come and go. A child can have them as a younger age and outgrow them, or they cannot have them and then develop them, and there really doesn't seem to be any proven method to change that. Cavities Obviously, a big thing, we want to make sure that the child's regularly receiving dental care, both brushing at home in the morning and at night and flossing, and then also being seen by a dental provider, a dentist, twice a year, so every 6 months is very important. Don't send a child to bed with a milk cup, juice cup bottle, because then it's just sitting on their teeth, and as much as they can do a straw, that's actually going to help bypass that liquid just sitting on their teeth as well. And then growing independence, this is just speaking to what are some of those additional principles we should be trying to encourage, and that is things like keeping a routine, teaching them roles and responsibilities, giving them appropriate chores, giving them time to communicate, allowing them a little bit of extra time to talk when they are, answering questions and you're the nurse performing that interview. In the hospital, we want to definitely explain what they can expect, but using language they'll understand. We want to involve the child as well as the caregiver and make them aware of any changes that are happening to the child's care. Remember, our decision-making opportunities for the kids should be choices that are plausible, not things that they aren't going to be able to decide. And then at home, we want to make sure that parents and caregivers can recognize signs of infection, that they have emergency phone numbers readily available to them. And then the mentioning of diet advancement is in the situation of like illness, say when a child's had vomiting and diarrhea, what's the appropriate way to restore their usual diet? Things like, minimal or really avoiding spicy, acidic foods, trying to eat more bland foods until they have kind of let that gut rest. And that's pretty much it. We talked about disaster plan and safe words already. So that concludes the